disorders. So the key concepts will be covering our acute ocular surface disease, how to manage in your practice, and some basic concepts about what constitutes limbal stem cell deficiency, how to approach it logically, and some of the various management options which are available today to deal with these conditions. So for the first talk, we have Dr. Ikeda Lal from Gangaram Hospital and Delhi Eye Center, Delhi. And she is going to tell us how to manage acute ocular surface disease so that it doesn't deteriorate into something worse in the chronic stage.
So thank you, Dr. Jayesh, for inviting me to this instruction course. So I'm going to just briefly tell you what to do in acute stage when we are faced with these patients. Now, the three important entities in acute ocular surface disorders include chemical injury, Stevens-Johnson syndrome, and active ocular cicatricial pemphigoid. Now, the treatment of active OCP, as we call it, is primarily systemic immunosuppression. Therefore, I'll just be talking about mainly chemical injury and Stevens-Johnson syndrome today in my talk. So, acute chemical injury is a true ocular emergency, and they constitute 7 to 10% of all ocular injuries. They commonly affect the young male population. Therefore, this is the productive age group of our society, and they have a significant impact on the family's income. Nearly 1/5 of these result in significant cosmetic as well as visual disability. Therefore, it's really important to recognize these cases and manage them properly in the acute setting. So, what can lead to chemical injury? In our scenario, amongst the alkali, the most common is lime or tuna. The typical scenario is that a little boy is sent to buy a tuna packet from the local vendor, and they come in these plastic bags. So on their way back, they tend to play with it, and the whole thing bursts open and hits their eyes, and the particulate matter can actually get retained in the upper fornix, leading to prolonged toxicity. Acids in general penetrate a little lesser than alkali, so they might cause less degree of burns, but amongst the acid, the hydrofluoric acid is the one which can penetrate very easily and can lead to burns as severe as alkali. So what do we do if we are approached with a case of acute chemical injury in our clinic? The dictum here is treat first, examine later. We should not waste this precious time to do a detailed slit lamp examination because the contact time with the chemical is extremely important. So just rule out open globe injury and then take the patient up for copious amounts of irrigation. This can be any fluid, whatever you can easily find, whether it is Ringer's lactate, BSS, normal saline, or if nothing is available, even irrigating with water is better than not doing anything at all. And while we are carrying out this irrigation, we should doubly evert the upper lid and make sure that there are no retained particulate matter present. So at least 2 to 3 liters of water for about 20 to 30 minutes of irrigation. After we have done this, we take the patient back to the slit lamp and then stain with fluorescein. Then we grade these patients depending on the severity of chemical injury based on clock hours of limbal involvement, which means that the clock hours of limbus which is actually taking up the stain and the percentage of bulbar conjunctival involvement. So here are a few examples. I'll just share with you how to classify these cases. So this is a grade 2 chemical burn. As we can see that less than 3 clock hours, about 2 clock hours of limbus is involved and less than 30% of bulbar conjunctiva involvement. So this is classified as grade 2. This is a little bit more severe, about 5 clock hours of limbus with a more extensive bulbar conjunctival involvement. Then we have the grade 4 injury where about 8 to 9 clock hours of limbus has been affected. We can just see the palisades is in this one region, and otherwise there's the whole surface is taking up the fluorescent stain. And then this is a very bad, severe case of burn, and as we can see, the conjunctiva is completely blanched. The whole ocular surface, the conjunctiva and the corneal epithelium was gone. And important point to note here is that even though we see these palisades, when you look at it, you can see these palisades, but when we stain them and they take up the stain, that means that this indicates limbal involvement, even though they look like they are present. So what really goes on in chemical injury? There is inflammation, collagen breakdown, and ulceration. So we need to stop this process, the cycle that has set in. So the principles in management include re-establishment of an intact corneal epithelial surface, shifting the balance towards repair rather than ulceration, and rigorous control of inflammation. So what all drops can we give to the patient? Topical steroids, frequent topical steroids to control inflammation. This is absolutely important that in acute stage of chemical injury, we need to put these patients on topical steroid, at least for the initial 7 to 10 days. And we can also add in oral steroids if needed. Cycloplegic eye drops, they provide symptomatic relief to the patient. Antibiotic, because they have large epithelial defects and you don't want them to get secondarily infected. Lubricant eye drops, to a certain extent, they promote epithelial healing, and maybe we can use ascorbate either in the topical or oral form, which minimizes ulceration and supports the process of repair. So what is the surgical management, and when do we need to take these patients up for surgery in the acute stage? So for surgery, we need to do amniotic membrane graft, and the indications for amniotic membrane graft in a case of chemical injury is that if it's grade 3 or above, there are extensive ocular surface burns. Even in lesser than grade 3 burns, we have to keep monitoring these patients very closely, keep staining the ocular surface and note down the epithelial defect, take the pictures so that we can objectively compare whether the patient is getting better or not. And if we feel that the response to medical treatment is not adequate, we should take these patients up and place an amniotic membrane graft. So this is a case of a 2-year-old child who came to me from a remote place, and this is already 15 days post-injury, and here I've taken her under general anesthesia. I'm averting the upper lid and making sure there's nothing there, and then we go ahead and remove all this unhealthy tissue. You can see all this white tissue over here, which is all ischemic, so we need to remove all this ischemic conjunctiva. Then this is the amniotic membrane graft. This is which is the fresh AMG which gets processed. So we use this. We don't use the dry or the freeze-dried AMG because it does not have as good properties as the fresh one. So we place the amniotic membrane graft on top of the ocular surface, and then we glue it down with the help of fibrin glue. I've just taken a couple of sutures in this case because the patient was a child and I didn't want to take her up for repeated anesthesia, so I didn't want to put a bandage contact lens on top. So just for safety purpose, I've taken a couple of sutures, absorbable sutures. Sometimes it is the injury is so severe that you need to cover the entire ocular surface with amniotic membrane graft. This case, the patient, the conjunctiva, there was no extensive defect, so I just tucked it under the conjunctival peritomy, but sometimes we might need to do a graft which covers the entire ocular surface as well. And in very severe cases, we might need to do a tarsorrhaphy where we expect that this is not going to heal, so just do a tarsorrhaphy, let the surface heal. That is our first aim. How does amniotic membrane graft help? So in the acute stage, it provides symptomatic relief to the patient, and also it significantly enhances the process of reepithelialization, especially in moderate grade burns. Now, in severe grade burns, this is a little more tricky, and we might need to repeat amniotic membrane grafts because sometimes the surface just does not epithelialize that well. So this is a paper from Shankar Netralaya by Dr. Geeta Iyer, and what they did in this technique was that they actually did an allogenic simple limbal epithelial transplantation, or allo-SLET, from a cadaveric donor. So like we get the tissues, the corneal tissues, we can take one of those and take the limbal stem cells from there and perform an allogenic SLET in the acute stage. This is in very, very severe burns, grade 4 and above. And the aim here was just to epithelialize the surface. And they found that the epithelialization time had significantly reduced with this technique. So now let's talk about the other important disorder we might come across. This is Stevens-Johnson syndrome. These basically come in the category of severe cutaneous adverse drug reactions. These are inflammatory conditions involving the skin as well as the mucous membrane, and they are mostly drug-induced. Clinically, they look like partial thickness burns, and you see all these lesions all over the face as well as the body. The two important clinical entities are Stevens-Johnson syndrome. When it involves less than 10% of the body surface area, it is termed as SJS. And when it is an extensive kind of a picture and it involves more than 30% of body surface area, then we categorize these cases as toxic epidermal necrolysis. And between them, there is an overlap. So this is what the patient of SJS would look like to us. He'd have all these lesions all over his face and his body, and this typical mucosal involvement of the oral mucosa is very common in SJS. So this gives us a clue. So when we take a closer look at the eyes, you can see that there can be, first we start from the lid margins. So it's very important to look at the lid margins. There can be these ulcerations, as we can see over here, with loss of eyelashes, and this conjunctiva is completely congested. And then we go ahead and stain these patients. So again, I'm highlighting the importance of fluorescent staining in these patients. Otherwise, we'll miss these critical findings. So even if the patient can't be shifted to slit lamp, because most of the times these patients are very critical and they can't be shifted to your OPD room. So we go bedside and we take fluorescent stain with us, and we can just carry our direct or indirect ophthalmoscope and put the cobalt blue filter on, and we can take a look at the staining pattern. So we must avert the upper lid and look at the tarsal conjunctiva, whether there are membranes or whether there's a large epithelial defect, and also the cornea, if there are any SPKs and epithelial defects present anywhere on the ocular surface. Now, medical ophthalmic management primarily consists of, one thing is you don't want a secondary infection again because there's a large bare area, so we give antibiotic eye drops. And most importantly, start corticosteroid eye drops. In these cases, there is a lot of inflammation and we need to give very frequent, about 2 hourly or even 1 hourly topical steroids, and we might need to add in oral steroids as well. So what is the surgical management and what we can do apart from just starting the drops? Again, amniotic membrane graft plays a very critical role for these patients. How it helps is that it promotes rapid epithelial healing, it reduces the amount of ongoing inflammation, it will also prevent the eventual scarring of the ocular surface and symblepharon. If there are bare areas and raw areas between the tarsal and the bulbar conjunctiva, they can get stuck together. And we should do this as soon as possible. If we can take the patient to OR, nothing like it. Otherwise, we can do a bedside AMG. So when do we do this? If there's intense lid margin inflammation and sloughing, or there's loss of eyelashes, when there's a large epithelial defect more than 1 centimeter and early symblepharon formation. These are the recommendations by Dr. Gregory in his latest paper published in 2016. But even less than 1 centimeter defects, we need to monitor them very closely. And if the defect is not healing, we should take them up for amniotic membrane graft. I would say that it's better to err on the side of doing an amniotic membrane graft rather than waiting for it to heal by itself. If you have a doubt, go ahead and do an amniotic membrane graft. And if there's any epithelial defect whatsoever in the cornea. So let's just take a quick look of how these membranes peel off. So this video just highlights that these membranes which are present on the tarsal conjunctiva, you can just pull them off and they come off very easily. So now once we remove these membranes, we'll have a large bare area which is created, and then we place the amniotic membrane graft on top of this bare area that we have. So I like to use fibrin glue so that we don't unnecessarily have to suture the amniotic membrane graft in place. So if we have access to fibrin glue, we can do that and just cover the entire bare area with amniotic membrane graft and iron it out nicely so that there are no tags and there's no wrinkling. And other very important point is that once we have ironed it out and placed it on the conjunctiva, we need to trim the edges, because if their edges are loose and we don't trim them like I'm doing over here, then the whole thing can just come off. And you don't want that the child opens and closes his lashes and there's some tag of AMG and then everything just comes off. Then we did the same thing in the lower tarsal conjunctiva, and after that we covered the entire ocular surface with an amniotic membrane graft and placed sutures. Now, these are the results. Again, this series is by Dr. Gregory, who probably has the largest numbers of, who's seen the largest number of acute SJS. And this is a case series of 10 patients where he performed amniotic membrane graft within 10 days of onset of the acute injury. And what he found out was that all of these patients, the visual acuity was more than 20/30 at 6 months follow-up, and all of them had just mild to moderate dry eyes. And as we know, sometimes in SJS, the sequelae can be very, very sight-threatening for the patient. So I'd just like to end here by saying that both of these conditions are true ocular emergencies. We need to act fast. Ocular examination is a must, and it should include fluorescent staining wherever possible on slit lamp, if not even bedside fluorescent staining. Frequent topical steroids must be started as soon as we see the patient. Close follow-up to keep monitoring the size of defects and the inflammation on the ocular surface, and take them up for amniotic membrane graft if the patient is not improving. For SJS, within 1 week, if you can do an amniotic membrane graft, that will be wonderful for the patient, and the consequences of scarring and dermatalization, keratinization will go down significantly. Thank you so much.
Thank you, Ikeda, for the nice overview of acute ocular surface issues. Please go ahead while we change the audio-visual for the speaker, the next speaker. You may come over here so that you can answer the questions.
Yeah.
Number one, regarding the dry amniotic membrane, you said it is not as good. In that case, how do we get the wet amniotic membrane? Number 2, does amniotic membrane transplant require similar permissions like keratoplasty or that was one issue? And the fibrin glue which you said, do we use that cyanoacrylate glue or the Relisil or the Baxter? I mean, if you can.
Okay, so the first question was regarding amniotic membrane graft. Right, so the fresh amniotic membrane graft, which is not actually fresh, but it is processed and then preserved, which is cryopreserved, which is much better as compared to the freeze-dried form that we get, because that is very dry. If the freeze-dried form, although I don't have any personal experience of using it, but what I've heard from other people is that it just works like a bandage and doesn't really do much. So we need here not just a bandage, but we need the anti-inflammatory properties of the amniotic membrane graft as well. We need the ocular surface to heal fast. So it's always better to avoid the freeze-dried form of amniotic membrane. And regarding where we can get it, well, you can procure it from L.V. Prasada Institute. They have a eye bank over there, and if you just write them a letter, they'll be able to help you out regarding that. And you can store it in the freezer for a very long time. So if you don't have a patient for a couple of months, you need not worry. You can use that amniotic membrane graft later as well. And then the question regarding the glue, so there are a lot of glues available in the market. And the one that works best, at least in my hand, is the Tarsal glue from Baxter, and all of us have the same opinion that that does a job beautifully. It requires about 8,000, need around 8,000 rupees, so it will add up the cost of the surgery. But the other brands, we are not so sure that they actually work as well as the Tarsal. Dr. Syed, would you like to share your experience with any other brands?
Yeah, so I agree with what Ikeda is saying, that if you are going to use glue, so it's best that you use, I don't have any financial interest, but it's best that you use Tarsal because it's very predictable. It does not give you any problems, and you can be 100% sure that this glue will stick. With Relisil, like we were just discussing in an earlier session on SLED, that it's about 50-50. Half of the time it works, half of the time it doesn't work. So it's unpredictable, so your result also becomes unpredictable because you don't know whether your procedure failed or had a bad outcome because of a technical problem or because of the glue or because of the membrane. Because then, you can't promise the patient any predictable outcome, and that becomes very difficult. So I would recommend using Tarsal until we have some other, maybe someday Orolab will come with a cheaper glue and then we'll all be happy. But up until that time, we have to do with Tarsal. And Relisil is maybe slightly cheaper, and then Johnson & Johnson has a glue also, but Johnson & Johnson also is not very, very good. So in terms of predictability, from your psychological point of view, you feel that you have done a good job and you know that technically, nothing is going to go wrong. I would say that you prefer using Tarsal. And definitely not cyanoacrylate glue. That's an entirely different compound and product. That's for sealing perforations and all. This is fibrin glue. So prothrombin to thrombin and fibrin, to fibrin is the conversion. So cyanoacrylate is an entirely different thing. Don't use that. And the third question about the permission, I don't think you need a keratoplasty center to do amniotic membrane. So right now, the amniotic membrane is fortunately under the radar of HOTA. Okay, and let's just keep it like that. So the more we discuss about this, it's likely that it will come over the radar, and then things will get complicated. I think we are running slightly late.
Does L.V. Prasad supply to a private practitioner?
Yes, it does. They'll send you in a cold chain, and you just pay them the money, and they'll send. So next we have Lieutenant Colonel Dr. Alok Sati, who is Associate Professor at the Armed Forces Medical College at Pune. And he will be telling us about how to logically approach complex ocular surface disease and limbal stem cell deficiency, how to categorize and classify it.
You can come over here. Good morning, everybody. At the outset, I would like to thank Jayesh for giving the opportunity to speak in front of this august gathering. The topic is ocular surface disease and limbal stem cell deficiency. Now, we all know that the presumed limbal stem cells, they reside at the limbus, that's at the basal layer of the limbus. And according to the XYZ hypothesis, one cell divides into two, and out of the two, one resides there and one goes centripetally across the cornea into the basal cell, and subsequently it further proliferate and lead to the number of layers that we see in cornea. Now, some of these cells, they even go superficially at the limbus, and here they are very important because they form a proliferative barrier between the corneal and conjunctival epithelium. So any state of limbal stem cell deficiency occurs when this cell count falls below a critical threshold, and that's what causes the limbal stem cell deficiency. So there are n number of conditions. One, it could be the heredity, where the microenvironment that is required for these cells to sustain is not there, so they are absent. Second, they are acquired, which could be because of some injury like chemical or thermal, or it could be secondary to some insult in the form of SJS or TEN. So if you look into the hallmark of limbal stem cell deficiency, we all know that there are three signs of it. One, the conjunctivalization of the cornea. This is seen here, you can see very well in this histopathological specimen. You can see this is the pannus which has been removed from the cornea. So we can see the goblet cells lying there. There are vessels, that is the second stage called vascularization. And third, we can see a lot of inflammatory cells which we see in these conditions. Now, the management, the ultimate management of limbal stem cell deficiency, basically, to my perception and what I have learned from the stalwarts, is it basically depends on three factors. One, what is the type of damage? Second, whether the damage is partial or total. And third, whether there is adequate tear film or not. So let's go to the type of damage. This damage can be one-time damage, as we see mostly in the chemical injury, because we do not expect the damage be ongoing in those conditions. And second is the ongoing damage, which we see mostly in SJS or TN, where the inflammation is continuous, so it's an ongoing process. So whenever there is one-time damage and there is an adequate tear film, I think the cell-based therapy, which the subsequent speakers will talk about, where, I think that's the choice of the treatment. But where there is ongoing damage, these cell-based therapies, I think, is not very conducive. Though in the early stages, people have tried even type 1 Boston keratoprosthesis, and even people have tried SLET, especially from the eastern sector of our country, but the long-term outcome is yet to come from those doers. The second, it could be, the damage could be the partial or total. So whatever be the damage, mostly the symptoms are pain due to recurrent erosions, decreased vision, photophobia, watering, and blepharospasm. So this is a patient with, you can see a partial, a sectoral limbal stem cell deficiency. You can very well see the conjunctivalization, especially in the superior temporal aspect, along with vascularization. Now, if we stain such patient, we find that there is a late fluorescent staining. And why this staining occurs, which later forms the vertex configuration, it is basically because the cells at the conjunctivalized surface, they are very loose. So those staining material, they directly hit the basement membrane, and that's how it stains. So let's come across various scenarios. I think the first scenario I'll put up to the Dr. Sayan. Dr. Sayan, if there is a patient with normal visual acuity, a localized limbal stem cell deficiency as seen here, and there is absence of tear film disruption, what will be your choice of treatment?
So, like you've already mentioned, you have a patient who has good vision, and the tear film is fine, but there is a localized limbal stem cell dysfunction or deficiency, but that is not causing any problem in the central cornea.
Yeah.
I would wait and watch, observe, give the patient symptomatic treatment, lubricants, maybe cyclosporin, or a short course of low-dose steroids initially to see if this can be reversed. Try to look for the cause of why this happened. If this is like a one-time event, like somebody had a chemical burn and has partial LSCD, then you can wait and watch, and it is usually okay.
Yeah, I think
whereas if there is a secondary cause for it, that there is a problem in the lid that is causing this, or the patient is a contact lens wearer, or the patient has some other problem, then I would try to address the cause.
Correct. So I think you have understood this point, because such patients are quite common in our clinical setup. And we often, try to do all heroism, but I think we should just wait and observe. The second scenario is this patient with reduced visual acuity, but the tear film is adequate. So Dr. Jayesh?
Yeah, So such a case typically would be a good candidate for cell-based therapy. Depends whether it's unilateral or bilateral. But we'll come to the therapy later. Right now, it's important for the audience to understand the different scenarios. So I think
the third scenario is you have there is no abnormal ocular motility. Like, there is symblepharon, but there is no ocular motility disturbance. So what do you think, doctor, about this patient? How do you think that the symblepharon should be touched, or let's do the cell-based therapy alone?
No, the important thing is that you have to look for, from an oculoplastic perspective, I would say, look for the closure of the ocular surface with the lids. Like if the symblepharon is causing much of disturbance in closure of the ocular surface and the ocular surface getting exposed, better to release the symblepharon, put an MMG or an AMG. Okay. If not, then you can observe.
I think if there is no ocular motility disturbance, we should leave it like that. Now, sometimes you have ocular motility disturbance, then of course you have to treat symblepharon, and the symblepharon treatment is always depends on whether the grade is mild, moderate or severe, and the gradation depends upon the length of symblepharon, width of symblepharon and inflammatory activity. I think that will be covered in subsequent lectures. Now, the other scenario is when you have the total limbal stem cell deficiency. You can see the conjunctivalization of the entire cornea. There is vascularization. And if we take the histopathological specimen of the spinous, we will see the inflammation also. Now, such patients often, present with PED, that is persistent epithelial defect, which may ultimately cause scarring, ulceration, corneal thinning, and even perforation. So this is scenario 1 in total limbal stem cell deficiency with extensive symblepharon formation. It is with adequate tear film, so obviously we have to release the symblepharon and do the cell-based therapy. The scenario 2 is, especially we see in patients with OCP or SJS, and you can see there is a dermatalization of the cornea, there is extensive symblepharon, there is a pharyngeal shortening, so the treatment becomes more complex. And I think that's also being covered subsequently. Yeah. So basically there are two situations. One is symblepharon formation and pharyngeal shortening. Thank you. I think I've covered.
For explaining so nicely the different scenarios. Next up, we have Dr. Sameer Mohapatra from LV Prasad Eye Institute, and he is an oculoplasty surgeon. The reason for inviting him over here is to give us a perspective on what are the things we can do with the surrounding structures, the lids, the adnexa, before actually going on to treating the ocular surface. So now that we understand the concept of acute ocular surface disease, the concept of limbal stem cell deficiency, let's hear from Dr. Mohapatra what to do about the lids and the adnexal structures before actually treating the ocular surface.
Good morning all. It's always a privilege to be part of this IC. And I'll be talking on the management of adnexal tissues in cases of cicatrizing ocular surface disorders. Now, basically, Stevens-Johnson syndrome, ocular cicatrices of pemphigoid, chemical burns, and toxic epidermal necrolysis are the common cicatricial ocular surface disorders that cause a variety of lid pathologies like keratinization of the lid margin, trichiasis, progressive entropion, pharyngeal foreshortening, and proper shortening of the pharynxes, and symblepharon. Now, all these things may cause a patient extremely symptomatic with photophobia, foreign bodies and burning sensation, diffuse SPKs over the cornea, and a persistent epithelial defect that really compromise the visual acuity of the person. Now, the pathomechanism lies in the fact that because of changes in the lid architecture, there is blink-related microtrauma, which induces a state of persistent inflammation of the ocular surface. In addition to that, because of a pharyngeal shortening, there may be incomplete closure of the lids in each blink, and that may cause a chronic exposure, and this all compromise the further ocular reconstruction which we aim at restoring the visual acuity of a person. Now, thus, here comes the role of an oculoplasty surgeon, where we aim to reconstruct the eyelids, the fornix, and the socket to correct trichiasis or diastichiasis if present, to prevent and to correct progressive entropion, so that the ocular reconstruction can be taken up further for visual restoration. Now, lid margin keratinization is one of the most common lid pathology that is being observed in cases of Stevens-Johnson syndrome particularly, but in other conditions also. And it can be graded from various grades, right from 0 to grade 3. In grade 0, you may have very, very minimal keratin or no keratin at all to grade 3, where it have extensive keratin involving the entire extent of the lid margin as well as extending into posterior 1 millimeter of the tarsal conjunctiva. So depending upon the extent of corneal involvement, we can decide upon doing a mucous membrane grafting over the lid margin with excision of the keratin, and that helps in relieving the symptoms of the patient. Now, there have been various literature regarding the use of oral mucous membrane graft to correct lid margin pathologies, and the advantages of using mucous membrane grafting is that it causes abrupt cessation of keratinization at the edge of grafted mucosa. It releases the scar tissue over the skin as well as of the tarsal plate. In addition, it increases the height of the lid, thus aiding in closure of the lids properly, as well as prevents exposure and microtrauma. The important factor is that the graft tissue or the donor site heals without scarring, and it undergoes very fast healing without any residual sequelae. Now, coming on to the very basic steps, first the lid margin or the lid is everted on a Desma retractor. The entire psychiatric tissue or the keratinized tissue over the lid margin is excised. Even if you feel that the posterior or the tarsal conjunctiva is involved, you can go ahead and excise the entire extent of the psychiatric tissue. Then you have to measure the defect. Then adequate size of the oral mucosal graft which has to be taken has to be marked either on the oral mucosa, labial mucosa, buccal mucosa, even nasal septal mucosa can also be used for this purpose. After a free hand dissection of the oral mucosa, and this can be performed both under local anesthesia as well as under general anesthesia. This graft is, defatting of the graft is done to remove as much of stroma as possible so that the graft uptake is good, the vascularity of the graft is maintained, and the graft is placed over the defect and is secured with glue. And I prefer putting a marginal suture on the anterior surface of the lid, so with continuous 80 Weichel suture, because that helps in good adherence of the graft to the tarsal bed. Now, the important pulse, what you have to remember here is that when you are measuring the graft side, it has to be, you should take a 20% of oversizing because to prevent graft contracture. Avoid buttonholing because this may compromise with the graft intake. And the oral mucosa can either be sutured or an AMG can be placed to give better comfort to the patient. Now, there has been a concept of using seared MMG by using a buccal or a hard palate graft or a nasal turbinate graft over the defects or the pathologies involving both upper and lower eyelid, in which the same procedure of excising the tarsal keratinized tarsal plate is done. Then a tarsal fracture is done so that an everting suture can be placed, so that the lid margin moves away from the corneal surface, and then over the defect a hard palate graft can be harvested and can be placed over the defect, and the lid can remains closed for about 6 weeks, after which the division of the graft is done to get a very, very nicely mucosa lined lid margins. Now, the advantage of this procedure is that a large defects over upper and lower eyelid can be covered, so that from hard palate we can take very large tissue which act as a buttress support or a buttress graft for giving both the mucosa lined surface as well as the support. It requires less operative time because both upper and lower lid can be operated in the same time, and because the graft has vascular supply from both upper and lower lid, there is better chance of graft survival. Now, the outcomes as have been studied is not only it causes reduction in the conjunctival inflammation, but interestingly, it improves the visual acuity in about 60% of the patients. If not improvement, it never deteriorates the vision. It has been shown that the visual acuity even remains stable in about 36% of the patient, and that is, I consider, a greater advantage in patients where a further reconstruction is always aimed at. Now, this is what can be exemplified from this patient, a 22-year female, which presented with extreme photophobia. As you can see from the pictures on this picture, you can see extreme photophobia. She was unable to look at the flashlight of the camera. After an MMG, you can see that she is quite comfortable and the photographs can be taken up very nicely. Now, the role of MMG in not limited only to lid margin or to correct lid margin keratinization. Sometimes in cases of extensive or very severe thermal burns, when the eye load doesn't open at all because of extensive symblophron and fornical shortening, MMG can be used to augment the fornix by putting a fornix formation suture, can be used to cover the entire ocular surface so that further perforation or further deterioration of the ocular surface doesn't occur, on which further a keratoprosthesis can be planned. Now, the next important pathology that comes in our way of treating patients is trichiasis with a progressive entropion. This is a very, very difficult and frustrating condition where the patient do come frequently to clinics, and here you can see that this old lady with a diagnosed to have OCP had an extensive or a severe grade of trichiasis involving almost half of the lid margin and with entropion. Now, in this condition, I prefer doing a tarsal fracture with an everting suture with an anterolaminar repositioning, which is very, very important. If you try, it gives a very good results. And if this trichiasis is sectoral involving less 1/3 to half of the lid, you can plan an pentangon excision with a direct closure. Now, giving you the very basic perspective of how a tarsal fracture is done, similarly, we evert the lid, and after everting the lid, a full thickness tarsotomy is done 4 mm from the lid margin in the line of extensive fibrosis tissue. Then an anterolaminar repositioning is done. Anterolaminar repositioning done where the anterolaminar, the skin orbicularis, is receded posteriorly to about 4 mm. And then after passing the everting suture, the lid margin or the anterolaminar can be sutured onto the tarsal plate. And this is what is the outcome just immediately after surgery. The another point is trichiasis. If it is very, very focal, involving less than 1/3 of the lid margin, you can well try with electrolysis. The only care what you have to take is that the needle has to go straight into the direction of the cilia, overcoming the resistance of the tarsus, and the care should be taken not to perforate the posterior lamina through and through. Now, in cases of persistent epithelial defect, tarsorrhaphy is a very, very good modality to prevent further deterioration of the cornea, where a permanent tarsorrhaphy requires separation of both anterior and posterior lamina, the gray line of both upper and lower lid, then subsequent attachment or alignment of the anterior lamina and the posterior lamina respectively gives a very nice closure and adequate healing. So last is the punctal occlusion. We aim at preventing dry eye in very, very severe cases where we use either punctal plugs or punctal cautery. But in our case, what has been reported in literature is punctal cautery helps in better results as compared to punctal plugs. And this can be is very simple procedure and can be done with a monopolar cautery. So the take-home message would be our aim has to be to resolve the ocular inflammation by reconstructing the ocular surface in order to restore the vision. So what we need to do is to do the best, which is best in your hands, to do at the earliest. Don't wait for something to heal and then do, and do the safest. Don't keep trying on different techniques. Whichever is the best, you should do it in the right time. Thank you.
Samir, very useful pearls for all of us. So maybe if anyone has a couple of questions for Samir while I set up the next talk, I'll be happy to take them.
There are a lot of patients like we face in symblophron and Entropion and all these SJs chronic ones, and bilateral. You did the lead, you did the symblophron, everything. And when it came to cornea treatment, I thought I'll send it to LBP and something will be done. So I talked also to Dr. Sangwan. And this patient is bilateral, so nothing was done really. I thought some cadaver, some limbal cell somewhere they will take and do something. Nothing was done. So this patient is virtually, he had PLPR and in one eye, very good pupillary reaction developed cataract. So I removed the cataract. So through small openings in cornea, somewhere he can see the hand movement and fingers, but nothing about cornea has been done. Can something be done?
So we'll come to that part of dealing with corneal problems in particularly in SJS. I have a talk on that. I'll just briefly speak on that. And then Jayesh is going to talk about cell-based therapy. And so cases that are very severe in which you cannot even do cell-based therapy, what are the options for those patients?
Yeah. So, good morning everyone. I am Jayesh Vazirani. So, We've seen how to manage acute ocular surface conditions. We've seen how to classify limbal stem cell deficiency into partial, total, depending on the etiology, whether it's a wet surface, a dry surface. And Samir has nicely elaborated what to do with the eyelids and the adnexa before you actually treat the ocular surface. So now, when we are treating the ocular surface, what are the different options? And one of the options, and a very good option, is cell-based therapy. So I'll just try and take you through what the cell-based therapy, how it has evolved over the years, and what is the current standard of care. So these are important points that Alok has already highlighted. We need to consider whether the surface with limbal stem cell deficiency, the eye, whether the surface is wet or dry, whether the limbal stem cell deficiency is partial, sectoral, or total, whether it's unilateral or bilateral, and whether the underlying cause, and this is important, whether it's an immune-mediated disease like SJS or OCP, whether it's ocular surface chemical and thermal injury, or whether there are some other rarer causes. It's very important to know whether the disease is active or whether it has smoldered out and now it's inactive. So all these things have a bearing on what therapy you choose and how you go about delivering that therapy. So let's take up unilateral disease first. Suppose you have unilateral limbal stem cell deficiency in a wet eye. Suppose it is partial. So one option would be to remove that pannus from the sector where there is LSCD and apply amniotic membrane. This has been tried, is often done even now. But long-term results indicate that unless this is supplemented with cell-based therapy, sooner or later in that sector, the limbal stem cell deficiency recurs or the pannus tends to come back and the cornea gets vascularized. So these are the long-term results. So when I say supplement with cell-based therapy, it automatically means limbal stem cell transplantation. So this has come into vogue since the late 80s and early 90s. The earliest techniques were, of course, direct limbal autografting. It started off with Kenyon and Singh's paper where they described taking 2 strips of 3 clock hours each of limbus and the adjacent conjunctiva from the donor eye, removing the pannus from the affected eye with LSCD and then transplanting these lenticles onto that eye. So that was known, if it was an autograft, as a conjunctival limbal autograft. Results are very good. Success rates in terms of stabilizing the ocular surface and improving the visual acuity generally range between 70 to 80% in different series. And this was the first limbal stem cell transplantation procedure formally written up in that way, and results were very good. What are the issues with this technique? The main issue is that there is a large amount of limbus that is taken from the donor eye, so there's always the potential for creating an iatrogenic limbal stem cell deficiency in that eye. And you can't repeat it from the same eye because you've already disturbed it quite a lot. So these are the main issues. So to counter these problems came up the concept of cultivated limbal epithelial transplantation in the 90s. And this then had become the standard of care, where we take a very small piece of limbal tissue, generally about 1 clock hour. You need a stem cell laboratory where it can be expanded ex vivo, and then you get an epithelial sheet which is transplanted onto the affected ocular surface. So it involves 2 separate surgical procedures and also involves the expense of having a very elaborate stem cell laboratory for expansion of these cells. Right? So this was done for many years, still being done at some centers, and basically the first step is taking a limbal biopsy, second is expanding it in the lab, and the third is to resect the pannus and put the epithelial sheet on top of the surface. This is generally after a couple of weeks of the limbal biopsy. Results were very good, whether it's in partial limbal stem cell deficiency or whether it's in total limbal stem cell deficiency. Rates of stabilization of the ocular surface and rates of improvement in visual acuity were comparable or better than that with direct limbal autografting. Very good procedure. The only thing is it's a 2-stage procedure. Most people in practice would not have access to such an elaborate stem cell laboratory, and therefore it is also expensive. So to combine the best of both worlds, now there is this technique which is known as simple limbal epithelial transplantation. The first paper describing this technique came out in 2011. Sayan here wrote up the paper and Dr. Sangwan came up with the technique. So what it essentially does is combine the best of the previous 2 techniques. We take a very small amount of limbus from the donor eye, 1 clock hour. It is cut up into pieces in the same sitting, in the same procedure. After resecting the pannus from the affected eye, the limbal pieces are placed on a scaffold of amniotic membrane with some fibrin glue and a bandage contact lens, and then they are allowed to grow in vivo. So you don't need a stem cell laboratory to expand the cells, and then you have an ocular surface which is epithelialized with corneal phenotype. So I'll just demonstrate this. This is a patient with alkali burns. You can see that there is pannus over the surface along with underlying corneal stromal scarring. And if we just quickly go through the steps of SLET. So here I am taking the limbal biopsy. Generally, because of reasons of convenience, you tend to take it from the superior part of the limbus. You raise the conjunctiva as a handle, dissect up to the limbus, take maybe 1 cloca 3 to 4 millimeters of limbus. If you require a conjunctival autograft, that can also be taken at the same time. And once the limbus is cut and the biopsy is taken, this is usually placed in your irrigating fluid, RL or BSS, till you dissect the pannus from the other eye. So this is the limbal biopsy. Then you go on to the other eye. This is an autologous procedure with unilateral limbal stem cell deficiency. So you do a peritomy and start from the scleral side and go towards the limbus and conjunctiva and try to take the pannus off the ocular surface. You try to peel it. In places where it is densely adherent or there is a lot of fibrosis, you may have to use a combination of blunt and sharp dissection. The idea here is not to remove all of the scarring from the cornea. The idea is to remove the vascularized pannus from the surface. The underlying scarring tends to regress over time. If necessary, it can be supplemented with a keratoplasty later. So you use a number of different techniques to peel off or dissect the pannus. Some very basic instruments are required, nothing fancy that you need to add to your OR. So you do the pannus dissection, you use your iris repositors, blunt dissectors, Vannas scissors, some forceps to try and get the pannus off the ocular surface. It's very important to delineate the plane where you're dissecting because you don't want to make incursions into the stroma. That causes more scarring, sometimes may cause perforation or thinning at that particular place. And once this pannus comes off, as you'll see later in the video, I don't have the controls here, I would have speeded it up. Yeah, so we're almost there, and the pannus you can see is coming off the corneal surface. The underlying stroma is scarred in certain places, clear in other places. And once this is done, you put some fibrin glue on the surface, apply amniotic membrane on the surface using this fibrin glue, secure it by tucking it underneath the margins of the resected conjunctiva. This is the other component of the fibrin glue being put in. And then once you have the amniotic membrane in place and it is secure, you can bring back your limbal biopsy that you had earlier taken and then chop it up into very fine pieces, get maybe 8 to 10 pieces at a minimum. You can use Vannas scissors, you can use a blade to chop it up, distribute the pieces over the surface of the amniotic membrane. Generally we try to spare the center of the cornea so that those transplants don't cause an opacity in the center if they are retained. Put some more drops of fibrin glue on the transplants to fix them in place, and then apply a bandage contact lens, and that is basically the end of the procedure. So you don't need a stem cell laboratory, you don't need 2-stage procedures, it can be done in 1 stage. This is how it looks at 1 week. Contact lens is taken off once the epithelium has healed. This is how it looks at 6 weeks. So I'll just show you a series of pictures where this procedure has been done. Some of my own cases. This is a 4-year child with acid injury, total LSCD. And this is following SLET. Again, this is a 30-year-old where SLET had been done earlier. There was some focal recurrence of LSCD and underlying corneal scarring. So we combined a corneal transplant with a repeat SLET, and you can see that the epithelium is growing from the limbal transplants, and eventually the surface is epithelialized. 30-year-old laborer with blast injury and completely obliterated fornicis, dermalization, and total LSCD. And this is the same eye after SLET with a conjunctival autograft, no other special procedures done. A 17-year-old boy with pesticide injury, SLET done twice earlier. You can see some focal incursions of the conjunctiva where the earlier limbal biopsy has been taken from the other eye. And this is again after SLET, the same eye. So we studied the outcomes in a multi-center study from various groups across the world, and we found that the success rates of SLET are as good, if not better, than the earlier procedures of CLET and CLAU. And this was reiterated by a recent paper with Cyan published, a very long case series, a very large case series, a very nice paper in ophthalmology where they found similar results, both in ocular surface stabilization and in improvement in visual acuity. Generally, rates are somewhere around 75%. So this is about autologous simple limbal epithelial transplantation from the same patient for unilateral limbal stem cell deficiency. If the LSCD is bilateral and you have a wet surface, well, you have a couple of options. You have a K-Pro, which Dr. Basak will be talking about, or you could do an allogenic limbal stem cell transplantation. Again, outcomes of which are good provided there is good systemic immunosuppression which is given lifelong. So earlier it used to be CLET, and now it can also be done using SLET. I believe this is one of science cases. The issues involved here is that you need to give systemic immunosuppression. There is the cost associated with these medications. Sometimes they need further surgery for vision restoration. The alternative, some Japanese groups have been suggesting cultivated oral mucosal transplantation, but we haven't found the visual outcomes to be very gratifying. The other alternative, and a good alternative, is a type 1 K-Pro, which we'll be talking about. So I'll just conclude by saying that your approach should depend on whether the surface is wet or dry, the involvement is partial or total, and whether it's a unilateral or bilateral case. Cell-based therapy is effective in stabilizing the ocular surface as well as restoring vision in appropriate conditions. Direct and cultivated methods are equally effective, and SLET right now, because it combines the benefits of all the previous techniques and minimizes disadvantages, is, I believe, the standard of care and the de facto go-to method for most surgeons right now. Pooled multi-center results show that it is as good or better than CLET. It is effective, repeatable, and replicable. So just to acknowledge the teachers from whom I am learned for. Thank you very much. And if you have any questions on cell-based therapy, I'll be happy to take them before we go on to the next talk.
As far as removal of those limbal cells is concerned, is it simple like the way we cut the conjunctiva for previously for ECC we used to cut it? Is it similarly
it
something?
Is simple provided you learn the right technique. You have to be, as science calls it, supra-tenons. So you don't need to involve the tenons there. You try to be superficial like you're taking a conjunctival autograft for pterygium surgery. It's important not to go very deep, and it's important not to go very far into the corneal stroma. So you don't cause stromal damage, perforation. You don't induce an iatrogenic limbal stem cell deficiency. We have videos, Cyan has videos, a lot of us have videos. So if you're interested, we can send you the link or the files. We can discuss it later. So if there are no more questions, then I'll invite Dr. Sayan Basu from the Center for Ocular Regeneration, Cornea Service at Tej Kohli Cornea Institute and the L.V. Prasad Eye Institute. And he's going to talk about what we can do when it's a bone dry surface or a very dry surface where these conventional options are really not applicable. So there's a slight flipping of the talks. Dr. Basak will cover the type 1 K-Pro later, while Sayan talks about the dry surface right now.
Thanks, Jayesh. Like Jayesh said, I'll talk about some of the more complex ocular surface disease presentations where even stem cell transplantation would not be an option. So basically, when you're talking about these kind of cases, you're essentially talking of very severe Stevens-Johnson syndrome or OCP or chemical burns that are in their end stage. And usually in the end stage, most of these diseases basically look very similar. So I'm going to keep the topic broad and discuss some of the cases and the outcomes. Let me do it. So first of all, it's very important to do a good clinical evaluation so that you know what kind of case you're dealing with, what is the severity, and then you can choose your management strategy based on that. So this, I think, is the most important part of the talk. So typically, let's say in chronic SJS, which is a very good example, because most of us, when you're talking about severe end-stage ocular surface disease, you're essentially talking about SJS, because that's very, very common in our country, and most of us deal with cases which are, SJS complications. You can also have severe chemical injury present like this, and it's almost identical, or you can have mucous membrane pemphigoid present like this, but they are much rarer. So it's important to examine the lids, stain the surface, and also look at what is the wetness on the surface. And basically these three parameters will determine how you address the clinical scenario. So you can have, very rarely, and this is in our experience, these numbers express the percentage of eyes that we see in our practice. So patients that are referred to us, about 15% of them have some lid margin disease like Samir was mentioning earlier, but may not necessarily have keratopathy because they have wet eyes. So these are the easiest to manage. You don't need to do any surgical intervention. You can just give them symptomatic care and they're fine. Then there are cases where there is lid margin disease and there is also some amount of keratopathy because of dryness, but not necessarily because of the lid margin disease itself. And you can have a very similar condition where you have a combination of lid margin disease and dryness, and the keratopathy is more due to the lid margin problem than the dryness. Now, how do you differentiate these two scenarios? Because your management in these two conditions is different. You can differentiate that with a fluorescein staining. So if you stain the surface and you get a diffuse staining of the surface, or you get a staining which is only in the interpalpebral area, you know that this is mostly due to dry eye. Whereas if you get a staining which is more prominent in the superior part of the cornea or the inferior part of the cornea, like you see in this photograph, then you know that the lids are at fault here. It's not just the dry eye. So that needs to be addressed. Whereas when you have cases which are dry as well as, surface is completely dermalized, like over here, that requires a completely separate strategy for intervention. So I'll describe, step by step how we need to do that. So if you have keratopathy due to lid disease, Samir has already talked about it, you need to address the lids because the lids are a problem. How did we know that the keratopathy is because of lid disease? Because we stained the surface, we saw that the superior inferior cornea, there is corresponding staining. I call this corresponding staining, meaning that the problem in the lid corresponds with the staining on the corneal surface. So this is how a normal lid looks like. This is how lids in SJS and OCP and in end-stage disease, ocular surface disease look like. And if you know that there are various things that you can do, you can just give them lubricants, you can give them scleral lenses, mini scleral lenses, you can do a combination, you can do mucous membrane grafting as Samir mentioned. But the question is which of them works best? So from our outcomes that we have analyzed, we have seen that a combination of mucous membrane grafting and scleral lens works best for improving visual acuity and maintaining visual acuity over a long period of time. MMG also works very well. Only medical therapy, which is this blue line, it does not really work very well. And about 50% patients who have lid margin disease and have keratopathy because of lid margin disease will have a significant drop in vision, at least will lose 50% of their vision in 2 years if you keep them on medical therapy. So it's very important that a patient with SJS or other end-stage disease who has lid margin disease should have a lid margin graft. And if you can give them scleral lenses as well, then there's nothing like it. So just to give you an idea of what happens if you don't do it. So these are patients who have clear corneas to begin with, but bad lids, dry eyes. This is what happens to them over months to years. Their surface gets completely dermalized and they lose vision. Now when they land up with this situation, then it becomes very, very difficult to treat. Okay? This is a very good example of a paired control. So in one eye, the patient had lid margin disease in both eyes. Right eye, the cornea was severely scarred and getting vascularized. Left eye, there was some scarring, but the patient had good vision. So we told, this is a young girl, she's about 12, 13 years old. So we advised that she goes for lid margin mucous membrane grafting. The parents were not convinced because they thought if the problem is in the cornea, why should you do surgery in the lids? So we at least convinced them for having the surgery done in the worst eye, which is the right eye. So this is what happened over 1 year's time. The eye which had the mucous membrane graft, and you can clearly see the mucous membrane graft here, improved from 2400 to 2060. And the eye that was the better eye to begin with, but also had lid margin disease, went from 2020 to 2060. So over a period of time, the worse eye, because the intervention was done in time, improved, and the better eye, because the intervention was not done in time, deteriorated. So there is a window of opportunity that we have with lid margin grafting that we should recognize and we should take advantage of. So this is how the lid margin looks after an MMG, and if you compare it with a normal lid margin, you can see that the normal anatomy of the lid margin, the smoothness of the posterior lid margin, etc., can be restored very well with mucous membrane grafting. And that is why it works very well. And this is a classic example, patient with ocular surface disease due to lid margin disease, mucous membrane graft had been done. I have put on this slide just to demonstrate to you the fact that even somebody, if you put in the effort, you learn the technique well. This is a surgery done by one of my fellows who's never done too many ocular surface surgeries before, but look at how nice a job he has done, because he's learned how to do this surgery well. So even cornea surgeons can do this and should be doing this because, and you can see the improvement in the corneal surface, etc. And if you have an oculoplasty surgeon, a colleague with you who can do this, then there's nothing like it. And the improvement is significant. This lady, young girl, actually, she was about 10 years old. This is just before Stevens-Johnson syndrome, had SJS, bilateral pseudomonas keratitis. We controlled the keratitis, did a tissue adhesive application, did mucous membrane grafts in the same patient, post-operative. Now she has 20/30 in the right eye and 20/50. She has scarring, which has now reduced over many years. But now she can open the eye, she can see, she can work, etc. And to the extent to which the mucous membrane grafting and reverse keratinization on the surface is another very good example. You can see these bands of keratinized epithelium on the ocular surface. This patient had a SJS as a reaction to anti-obesity medication, young lady. And this is post mucous membrane grafting and adequate lubrication. You can see that these bands of keratinized epithelium are totally gone. And the patient has very good vision. Now, if you have keratopathy due to dry eye disease, now the lid margin is not that bad, but the eyes are very, very dry. But the cornea is still clear or relatively clear. Patient has some vision. You don't need to do a corneal procedure yet, but you want to preserve the corneal clarity. What do? Now, you can keep the patients on medical therapy. That is one option. But just like I've told you that if you know that these patients only on lubrication will end up having keratopathy and recurrent ulceration, vascularization, and then eventually lose vision. This is a very good example. Right eye, you can see this diffuse staining. Left eye, the eye is wetter, but you can see this selective staining in the lid margin. So this is a perfect case which demonstrates that the right eye, the dry eye needs to be managed. In the left eye, the lids need to be managed. So if you do a lid margin grafting in the right eye, it will not help because it's a dry eye related problem. In the left eye, if you do a mucous membrane grafting, it will help because it's not a dry eye related problem, it's a lid margin related problem. So look at the selective staining over here in the superior inferior part of the cornea. Now, we do a procedure which is called minor salivary gland transplantation or MIST. Now, this is similar to a lid mucous membrane grafting, but you take a larger amount of tissue. You take the minor salivary glands that are present in the lip. You take a huge bulk of it, and you put it in the superior fornix attached to the superior rectus, and you create some space for it. Just for the sake of time, I've just shown you a collage of photographs, and this is how it looks post-operatively. And when you remove the speculum, it slips into the superior fornix, and it's not cosmetically visible. But what it does is that it produces the saliva-like secretion. It is autonomous. It is not reflex secretion like you have. So just like you have accessory lacrimal gland and reflex secretion of the tears, it's the same principle. And this is how it looks on first post-operative day and after a week. And you can see significant improvement in the ocular surface staining because of the lubrication that is produced on the surface. So this will help in preventing end-stage disease developing. And this is the gland, how it looks. So improvement in the surface and also in the patient's symptom ability to open the eyes. And finally, with end-stage keratopathy, like sir was asking earlier, what do you do with patients who have the cornea is already decompensated because of the surface problem? Now, I'll give you some examples. This is a patient with anti-TB reaction, SJS, bilateral LSCD, both eyes desmetocele. So your options are very limited here. Here, no cell-based reconstruction work because the cornea is too thin, but the eyes are wet. So you can do a modification here. So what we did is initially we did a fornix-forming mucous membrane graft to open up the space, and then we did a type 1 keratoprosthesis, which Dr. Basak is going to talk about. But here what we also did is that we preserved the surface pannus and covered the whole keratoprosthesis with the pannus. This patient follows up with Vikas Mittal in Ambana, and he has 20/30 vision, N6 vision in his eye, now 3 years out. And because we have protected, taken care, so we did 2 or 3 procedures. Just one shot cure is not possible in these cases. This is a young child who had a keratoprosthesis in the left eye, vitritis, end off, lost the eye, referred for a keratoprosthesis in the right eye. I did not want to do it because he had already lost the left eye due to K-Pro. So I did an allogenic slit in the right eye, and this is the right eye before surgery and post of surgery recovered vision. Jayesh showed you an example. This is a patient who presented with SJS. Initially the cornea was clear, later it got dermalized. We did mucous membrane grafts first, then did an allogenic slit from the father. Now the patient sees 20/100 with scleral lenses. This is the same case that Jayesh was showing. This patient just came to me. I saw her on Thursday, 3 years out. Superior severe symblepharon granuloma, LSCD. We did a allo slit, but we also did a mucous membrane graft to form the fornix. So a combination of procedures. Now finally, in cases which have dermalized surfaces, where the cornea is, there is no tearing and the total dermalization of the surface, then your options are very limited. You can either do a MOKP or a type 2 K-Pro, and now we have considerable experience with the OKP, but we are doing a different procedure now because of the problems associated with the OKP called the LVP K-Pro that you can do under the cover of a mucous membrane graft. So again, the mucous membrane graft comes handy, and this is called the LVP K-Pro. So you do a K-Pro which can be protruded through a hole in the mucous membrane graft, and the patients can get good vision, etc. So, the disease presents in various forms. So you have the acute presentation of SJS where Ikeda talked about appropriate medical therapy, amniotic membrane transplantation. You have the chronic presentations of lid margin keratinization with keratopathy where you do MMG pros or scleral lenses. You have dryness related keratopathy where you can either keep the patient medical therapy, anti-inflammatory, or do minor salivary gland transplantation. Or you have patients with, everything is fine but the keratopathy is very bad, you can do allogenic slit. or you have severe cases where your only resort is K-Pro. So there's it's a range of therapy that are available, but you need to understand the algorithm and the principle. So if you have a patient with dry eyes but you do SLED, it will not work, you know. Similarly, if you have a patient with wet eyes and has only keratopathy, there's no need to do a K-Pro. So you have to pick and choose depending on what the presentation is, and if you understand the algorithm and you're adequately trained in doing all these procedures, you can actually, through a combination or doing procedures appropriately alone, you can use that management algorithm to treat these patients appropriately, and they can get good vision, you can preserve their vision and also restore it. Thank you very much.
Thanks, Sayan. That was a wonderful talk. Any couple of quick questions while we change the presentation? Yeah.
Like, I have two child, again, females, and they have unilateral this problem. What do you think would be the etiology of that unilateral? Lip margins get keratinized and they have the corneal problems. Other eyes are right, normal. And only thing I found that they were malnourished.
Yeah, I have seen some of these cases with unilateral lid keratinization and dryness, etc. Some of these patients had radiotherapy for some nasal sinus tumor, etc. Some of them have some vague history of chickenpox, but it's very asymmetric. One eye is completely normal, the other eye is very advanced. So we can use these, like if it's dryness is the problem, we can do a minor steroid and transplantation. That helps. So that's what I'm saying, that there is usually a history of some antecedent, like some people give a vague history of chickenpox, some people give just history of dryness. It might be some severe adenoviral conjunctivitis. There's basically a destruction of the cellular unilateral. I've seen those cases. So I'm not exactly sure what is the cause, but these cases do exist.
So if there are no more questions, our next speaker is Dr. Samar Basak from Desai Hospitals, Calcutta. And he is going to tell us about the type 1 keratoprosthesis, how, when to use it, how to follow up, and the other details. Dr. Basak.
So basically my talk is on Boston K-Pro on end stage OSD. This is a patient, 51-year male, only eye, 6-time failed graft. You see the amount of vascularization, its surface changes. So what do we do next? The only answer is Boston K-Pro 1. Otherwise wet surface. So we did Boston K-Pro about, this is now 7th year running, and this patient is doing still good with 624 vision. IOP is going normal. He had macular scar. This is another patient, thermal and chemical injury, had 12 surgeries earlier. We did K-Pro with Ahmed glaucoma. This was the situation of both the eyes, left eye lost and right eye was so devastating. So we did K-Pro in this eye. Down the line, 4.5 years, he is enjoying good vision. He is in regular follow-up with every year now with me. So OSD with, already Shayan has told that OSD with wet ocular surface, we have a lot of choices, but OSD with bad ocular surface, the only choices are either Pintucci, type 2, or LVP K-Pro, or OKP. So autoimmune cases of group are difficult to manage. Shayan has already elaborated nicely. So, but there are some cases you could still do, because all those OKP and type 2 are very difficult and may not be one-stage procedure for all the times. So you have these two groups, SJS and MMP. You can, in selective cases, you can also try Boston type 1 also. So, but as I said, that case selection is important, otherwise this thing will happen. This is an initial experience we didn't have, so the more and more we are doing, we have that patient, as you see that even after this, before there was no keratinization, this patient developed keratinization and later on developed frank ulcer. So more chances of retention failure. And these are, of course, as I said, that there is no scope for Boston type 1. Other types are there. I am quickly skip it. But recently we have published this data on cornea. that in SJS, what is the status of Boston type 1. So it is a collaboration of 3 hospitals, our Aldave and from Benguita from Philippines. So we have seen that it is not that bad. If you select them, you are proactive. You are serious about the concern about the follow-up. This patient, many of these patients do good. SJS, you see that we have compared this SJS with non-SJS group. So persistent epithelial defect is the main problem in SJS group. And if you say that, we have to do lot of tarsorrhaphy in these cases, sometimes double tarsorrhaphy from both sides. So overall, this group is also going parallel if you have selected this SJS patient rightly. This is one of the Aldave's case. You see that, again, that experience is very important. So he did later on type 2. This is one of my case. You see that patient right eye, left eye. So after 1.5 years, as Shayan was telling, that we always try to cover it, try to give more vascularization. Still there is a gap. So I did bucket handle type of conjunctival flap with amniotic membrane. This is 2.5 years. Then I did lateral tarsorrhaphy here. And this is after 4.5 years. This patient is still following right now 6 years. So improving outcomes of SJS in Boston requires proactive intraoperative and postoperative management to cover the donor cornea. Conjunctiva in the form of tension-free tarsal bulbar conjunctival flap. Extensive median and lateral tarsorrhaphies are required in these cases. And MMP is little better than SJS. Chemical and thermal burn, you see that this is also firecracker injury. Sometimes we need to do, along with it, Ahmed glaucoma valve and tarsorrhaphy in the same sitting. So this patient is happy after 5 years. And we need to do like UBM in these cases to whether this patient is requiring AGV or not. This tells yes, they require AGV because no anterior chamber. And we combine this, and this is another patient I want to share with you. 16 years, both eye alkali burn with this kind of picture. There is a intermittent fistula here. I took up this case and 6/12 unaided and finger tension normal. It was surprised because all of us have seen that PR inaccurate in this patient. So he is a government sponsored patient, so no question of money for him. So we did the operation, and you see the disc and field is good. So these are the things you have to look for when you are in following up these cases with these severe cases. And this is my last case. I'll show that I did lateral tarsorrhaphy, and just few days back, this is the day of operation, I take the photograph. I did just a chink of, so this patient, it is about 6 months back, this patient is doing fine. So this both medial and lateral tarsorrhaphy, just making a small slit in the center, is also going good. So my data so far in this group is SJS 15, only 53% retained, MMP 5, 80% retained, chemical and thermal 84% retained. Others, like other groups are there. Total I have done 118 so far. Overall retention is 77%. But you see that this group is not so inferior, except SJS. We'll need to learn a lot for this SJS group. So take home message is Boston K-Pro is a good option in selected case of end stage OSD. It has a better prognosis for chemical and thermal bulb than SJS MMP. With surface keratinization, other challenges, actually other options are there. Perfect case selection, each and every case and very close follow-up are the key of success. And you have to counsel the patient that he or she may need multiple surgery even after primary K-Pro surgeries. Thank you very much.
Thank you, Dr. Basak. That was a wonderful case-based explanation of the oro-K-Pro. Maybe you'd like to take a couple of questions while we switch.
Most
To wrap up the session, I'll just very quickly deliver some key take-home messages from all the stalwarts that we've heard and just make some sense of it with a sort of a unified algorithm of how to approach these complex ocular surface disease cases. Right. So the first message from this session that we want all of you to take away is that before you actually think of doing surface reconstruction or K-Pro or any other sort of surface surgeries, you make sure that you fix any exposure, any entropion, ectropion, lid tissue loss, lid margin pathology. Lid margin mucous membrane grafts are an excellent modality for the appropriately chosen cases, as Sayan and Samir have shown. And you address the phonacial deformity. So this is the message number one, that first address the adnexal issues before doing anything else. Second thing is, keep in mind the cases that you're seeing, whether they are wet or dry surfaces, whether the limbal stem cell deficiency is partial or total, unilateral